Hello everybody. Today we are going to discuss about idiopathic thrombocytopenia. Immune thrombocytopenia is the autoimmune disease characterized by the isolated thrombocytopenia. Patient may be asymptomatic at presentation or they may present with mild mucocutaneous to life-threatening bleeding. Although only 5% of patients with ITP present with the severe bleeding. Bleeding leading to the hospital admission within 5 years after diagnosis develop in approximately 15%. Irrespective of the bleeding problem, patients with ITP often report fatigue, impaired health-related quality of life. The risk of venous thromboembolism is twice as high among patients with ITP as among persons in general population. The management of venous thromboembolism may be especially problematic given concomitant risk of bleeding. The ITP may be primary condition or may be caused by other diseases. The differential diagnosis of thrombocytopenia and the potential secondary causes of ITP are outlined in the following table. Like differential diagnosis of the ITP are pseudothrombocytopenia, renal and the liver disease. In pseudothrombocytopenia, the clinical findings will be no symptoms in vitro phenomena. The other test and the finding to confirm diagnosis are platelet aggregation on peripheral blood smear, repeat platelet count in the citrated blood. Then in renal or the liver disease, the other test and finding to confirm diagnosis are renal function and liver function test and the imaging of the abdomen, including liver and the spleen. Then myelodysplastic syndrome and the acute leukemia, other cytopenia and the abnormal peripheral smear will be present. Peripheral blood smear and the bone marrow aspirate and biopsy with flow cytometry and cytogenetic testing. Then the other differential diagnosis is aplastic anemia, in which pancytopenia is present. Bone marrow aspirate and biopsy will show with cytogenetic testing will helpful in the diagnosis. Then genetic disease that causes thrombocytopenia includes Burnout-Solier syndrome and the MYH9 related disorder. The presentation will be young at patient will be young at presentation. Family history of thrombocytopenia will be present. Abnormal size and the morphological feature of the platelet or abnormalities seen in the neutrophil on peripheral blood smear. Other clinical abnormalities are renal disease and deafness in patient with the MYH9 related disorder. The other tests which will helpful in the diagnosis are peripheral blood smear, mean platelet count, and the genomic testing. The next differential is thrombotic thrombocytopenic purpura. The clinical findings will be neurological and cardiac symptoms. The other findings will be presence of schistocytes on the peripheral blood smear, elevated LDH level, low hepatoglobulin, and Adams TS13. Direct antiglobulin test negative hemolytic anemia. Then heparin-induced thrombocytopenia. The clinical findings will be venous thrombosis, previous history of heparin. The test will be platelet factor 4 heparin antibody test in the platelet activation assay. Secondary causes of ITP is use of certain drug, that is sudden onset after initiation of new medication. Like common drugs include quinidine, acetaminophen, apixaban, carbamazepine, rifampicin, and vancomycin. The test to detect drug-induced antibodies if available. Then lymphoproliferative disorders like chronic lymphocytic leukemia and Hodgkin's lymphoma. The clinical features will be weight loss, night sweat, lymphadenopathy, or splenomegaly. The lab diagnosis will be complete blood count, peripheral blood flow cytometry, bone marrow flow cytometry or both, bone marrow aspirate and biopsy, protein electrophoresis imaging of abdomen, chest, and neck to assess lymphadenopathy and spleen size. Then immunodeficiency syndrome, for example, common variable immunodeficiency and autoimmune lymphoproliferative syndrome. The clinical findings will be hypogammaglobulinemia, cytopenia, frequent infections, colitis, lymphadenopathy, and splenomegaly. The lab features will be immunoglobulin quantification, lymphocyte subset count, and genetic testing. The infections like HIV, AIDS, HPV, HCV, cytomegalovirus, EBV, and H. pylori. Other supportive signs and symptoms at risk of population. The uh, Lab diagnosis will be serological and PCR test for HIV, HBV, HCV, cytomegalovirus, EBV, breath and stool antigen test for H. pylori. The other autoimmune disorders like systemic lupus erythematosus, rheumatoid arthritis, and antiphospholipid syndrome. The clinical features will be arthralgia, arthritis, hair loss, sun sensitivity, mouth ulcer, rash, and thromboembolism. Then lab features will be which will help in diagnosis will be test for antinuclear antibody, rheumatoid factor, anticyclic citrulline peptide antibody, and antiphospholipid antibody. Then the next differential diagnosis is Evans syndrome, that is thrombocytopenia, and direct antiglobulin test positive hemolytic anemia. The lab features which will help in the diagnosis is peripheral blood smear, measurement of hepatoglobulin and LDH level, and direct antiglobulin test. Then incidence of the ITP. Overall, the incidence of the ITP ranges from 2 to 4 cases per 1 lakh person in a year with two peaks. One between 20 to 30 years of age with slight female predominance, and larger one after 60 years of age with the equal sex distribution. Although some patients have one episode of ITP followed by immediate remission, chronic ITP develops in up to 70% of adults with this condition. Both spontaneous and treatment-induced remission can occur many years after diagnosis. Now about pathogenesis of ITP. Pathophysiology of ITP is complex and remain incompletely understood. The traditional concept is that antibody-coated platelets are prematurely destroyed in the spleen, liver, or both through interaction with the Fc gamma receptor. Autoantibodies can also induce complement-mediated or the deacylylation induce destruction of platelet as well as inhibit megakaryocyte function. However, antiplatelet antibodies are not detected in up to 50% of patients. This raises the possibility of alternative mechanism of platelet destruction. Abnormalities in the T cell have been described, including skewing of T helper cell towards the type 1 helper T cell and type 17 helper T cell phenotype, and reduction in the number and the function of regulatory T cell, which could drive the autoimmune process. Limited studies suggest that CD8 cells are also in. The pathophysiological features of the antibody is the pathophysiology of immune thrombocytopenia is completely understood, but the key event is considered to be the production of antiplatelet autoantibodies. These autoantibodies direct platelet for destruction by megakaryocyte in spleen, liver, and or both through activation of the Fc gamma receptor. This process is controlled by the spleen tyrosine kinase. Autoantibody may also destroy platelet through other mechanisms and inhibit platelet production by megakaryocytes. Antigen from the phagocyte platelet are thought to be presented by MHC2 with the 2 T cell receptor, stimulating autoreactive T cell. So T cell changes are seen in IT. So main T cells are involved is type 1 helper T cell, type 17 T cells. So the diagnosis ITP is defined as platelet count below 1 lakh per cubic millimeter in patient in whom other causes of thrombocytopenia have been ruled out. Clinical history, including assessment of use of drugs, physical examination, complete blood count, is important to rule out other cases of thrombocytopenia or to evaluate for secondary causes of ITP. Examination of the peripheral blood smear in patient with ITP showed reduced number of the platelet with no other abnormalities like schistocytes or dysplastic changes. Although some patients have large platelet and this is not pathognomic feature, there is no diagnostic test for ITP, and antiplatelet antibodies are detected only in 50 to 60% of patients with ITP, and measurement of such an antibody is not recommended in diagnostic work. Bone marrow examination is not diagnostic in patients with ITP and performed only in those with other hematological abnormality and those who do not have adequate response to the treatment. A peripheral blood smear and bone marrow aspect. Peripheral blood smear shows thrombocytopenia and normal erythrocyte in the peripheral blood smear, and panel B shows bone marrow in patient with ITP with good cellularity, normal development of the erythroid and myeloid cell, and increased number of megakaryocytes. So treatment is consist of treatment of active bleeding. Uh, Current goals of treatment are to stop active bleeding and reduce the risk of future bleeding. If the patient has active serious bleeding, urgent treatment is indicated. Specific measures where appropriate include withdrawal of anticoagulant and antiplatelet agent and treatment with the platelet transfusion, glucocorticoid, intravenous immunoglobulin, or all of these measures. Data from the randomized trials are lacking, and use of this treatment is supported generally by the small observational studies. Platelet transfusion can help to limit bleeding, but they have only transient effect, and therefore patient may need undergo transfusion repeatedly. They should not be used alone, but rather in combination with IVIG and glucocorticoid. IVIG raises the platelet count within 1 to 4 days in 80% of patients, but effect lasts only 1 to 2 weeks. IVIG is indicated in patients with active serious bleeding and in those with very low platelet count. Concomitant use of IVIG and glucocorticoids are associated with the more sustained response. In life-threatening situation, additional treatment may be required. Antifibrinolytic agents like tranexamic acid may help to stop bleeding, particularly from mucous membrane, and menorrhagia can be treated with hormonal therapy. Now, the treatment to prevent future bleeding. In patients who are asymptomatic or have only mild mucocutaneous bleeding, the decision to treat should be guided by the risk of future bleeding and patient preference. However, predicting the risk of future bleeding among patients with the ITP is challenging. Several scoring systems have been developed, but their usefulness in clinical practice is limited by their complexity and the lack of validation in larger studies. Platelet count of less than 20,000 to 30,000 is frequently used as criteria for the treatment. This criteria is consistent with the finding of increasing 1 year risk of bleeding, requiring hospitalization in 2.5 times among patients with platelet count between 25,000 to 50,000 and 7 times among those with platelet count below 25,000 per cubic millimeter. However, treatment decisions should also be taken into account other risk factors that influences the bleeding. These include older age, history of bleeding, concomitant use of anticoagulant and platelet inhibitor, the presence of complex conditions such as renal impairment, risk of trauma from the daily activities. It is generally recommended that patients who are receiving anticoagulant and antiplatelet agent should receive treatment to maintain platelet count above 50,000 per cubic millimeter. About glucocorticoid, glucocorticoid treatment is the standard of initial therapy for patients with IT. Two commonly used regimens are pulse dose high dose dexamethasone or more prolonged course of oral prednisolone or prednisone. In meta-analysis of randomized control trial comparing these two regimens, platelet counts were higher at 14 days in patients receiving dexamethasone, but overall response at 6 months did not differ significantly. Adverse effect events such as weight gain and Cushingoid appearance were more prevalent with the prednisolone and the prednisone and the prednisolone. Other studies have suggested more neuropsychiatric effect with dexamethasone. Although 60 to 80% of patients with ITP have initial response to glucocorticoid, only 30 to 50% of adults have sustained response after glucocorticoids are discontinued. In some studies, continued use have been associated with higher incidence of long-term remission, but prolonged exposure to glucocorticoid is not recommended because of adverse effects. Other medical therapy. Medical therapy for patients with ITP who do not have initial response to glucocorticoid or who have recurrent decrease in platelet count after glucocorticoid are discontinued include thrombopoietin receptor agonist or immunomodulator. Among available options, thrombopoietin receptor agonist rituximab and the fostamatinib have undergone most rigorous study under address below. Thrombopoietin receptor agonist, eltrombopag and the romiplostim are thrombopoietin receptor agonists that are approved by Food and Drug Administration for patients with ITP that is refractory to other treatment and with the disease lasting more than 6 weeks and or 12 months. Although these agents have not been compared head to head, the incidence of response appear to be similar. Meta-analysis of 13 randomized trials of either agent showed that, as compared with placebo or standard of care, they were associated with significantly higher rate of platelet response and durable response, and they reduced the episode of bleeding and the use of rescue and concurrent medication. Eltrombopag is administered as a daily tablet, where romiplostim is administered in the weekly subcutaneous injection. The choice between two agents is guided by preferred form of administration and anticipated adherence. Limited observational data suggests that if one agent is ineffective, switching to other result in platelet response in up to 50% of patients. An initial response to thrombopoietin receptor agonist usually occurs in 1 to 2 weeks. Once response is achieved, ongoing treatment is ordinarily required to maintain treatment. However, retrospective and prospective cohort studies have shown that 10 to 30% of patients can discontinue treatment after receiving thrombopoietin receptor agonist for months or years, and disease remain in remission although late relapses may occur. In earlier studies, the concern were raised regarding possible adverse effect of this agent on bone marrow. However, these effects are not been confirmed with more than 10 years of follow-up, and moderately increased bone marrow reticulin fibrosis have been observed in fewer than 10% of patients treated with either of these agents and has been reversible on discontinuation. The main safety concern is increased risk of venous thromboembolism. Extension studies of both agent thromboembolism report developed in 6% of patients during median follow-up of 2 years. Thromboembolic events occurred predominantly in patients with coexistent condition and the risk factor. Although the underlying ITP may partially account for these findings, the incidence of venous thromboembolism in this clinical trial was higher than the expected, which raises the possibility that thrombopoietin receptor agonists may tip the balance to thrombosis in susceptible patients. Other adverse effects of eltrombopag include elevated liver aminotransferase level and cataract. Avatrombopag, another oral thrombopoietin receptor agonist, which unlike eltrombopag can be administered without dietary restriction, was approved by FDA in June 2019 for the treatment of adults with chronic ITP. Now about immunomodulator. Rituximab is most widely used immunomodulator in patients with ITP, although it is not approved by FDA for this indication. A systemic review of a single group study showed that response in 60% of patients with complete response in 40% of patients. Meta-analysis including 5 randomized control trials showed significantly higher incidence of complete response at 6 months with rituximab than with the glucocorticoid or placebo. A response to rituximab is typically observed within 1 to 8 weeks. The main advantage of rituximab is sustained platelet response that lasts for more than 2 years in 50% of patients who have a response. Although ITP eventually relapse in most patients, most of those in whom disease relapse have a response to retreatment with the rituximab. An increase in minor infection has been reported with the rituximab. However, major complications such as progressive multifocal leukoencephalopathy are exceedingly rare. Then Imatinib is the oral spleen tyrosine kinase inhibitor, was approved by FDA in 2018 for patients with ITP in whom one previous therapy has failed. In pooled randomized trial, a stable response that is defined as platelet count of more than 50,000 per cubic millimeter on at least 4 of 6 visits twice a week during weeks 14 to 24 was achieved in 18% of patients receiving fostamatinib and 2% of those receiving placebo. A response was achieved in 43% of patients receiving fostamatinib and 14% those receiving placebo. Mean time to response was 15 days. Diarrhea, hypertension, transaminitis, and nausea were common adverse effects that occur in up to 30% of patients. Other immunomodulatory agents such as mycophenolate mofetil, azathioprine, dapsone, and the danazol are also used in patients with the IT. Data to support their use are largely limited to retrospective observational studies that suggest that 30 to 60% of patients have response. A systemic review showed that splenectomy, which remains most effective therapy for ITP, induced long-lasting remission in 60 to 70% of patients. Nevertheless, owing to emergence of effective medical therapy, potential complication of splenectomy, and inability to predict which patient will have response. Consideration of splenectomy is usually limited to patients who do not have response to or cannot receive standard medical therapy because of side effects or in whom at least a year has passed since diagnosis. The frequency of the splenectomy has decreased substantially during past 2 decades. Short-term risk of splenectomy include operative and post-operative complications, including venous thromboembolism and sepsis. Laparoscopic splenectomy is associated with lower post-operative mortality and morbidity and shorter recovery time than the open splenectomy. Although the immediate risk of venous thromboembolism can be reduced by thromboprophylaxis, epidemiological studies have shown persistent doubling and quadrupling of the risk of venous thromboembolism among patients with ITP who have undergone splenectomy as compared with those who have not undergone splenectomy. Although immediate risk of venous thromboembolism can be reduced by thromboprophylaxis, epidemiological studies have shown persistent doubling and quadrupling of risk of venous thromboembolism among patients with ITP who have undergone splenectomy as compared to who have not undergone splenectomy. Patients who have undergone splenectomy have increased risk of infection with encapsulated bacteria and require repeated vaccination. A large registry-based study showed higher risk of both early and the late sepsis among patients with ITP who have undergone splenectomy than among those who don't. The higher incidence of other vascular complications such as coronary artery disease, stroke, and the chronic thromboembolic pulmonary hypertension has been reported among patients who have undergone splenectomy, but data are not consistent among studies. Conversely, one study showed no significant difference in mortality in 5 years after splenectomy and the lower risk of death after 1 year among patients with ITP who underwent splenectomy than among those who do not. Splenectomy generally not performed in frail elderly patients because of increased surgical complications in this group. It is generally not performed in patients with secondary ITP owing to lower incidence of response and more adverse events. So this is the summary of the treatment line which we are using for the ITP. So the first treatment is prednisolone, that is 1 to 2 mg per kg of body weight orally for 1 to 2 weeks followed by gradual tapering. Usual onset of action is 1 to 2 weeks. Side effects are weight gain, insomnia, acne, mood changes, Cushingoid appearance, glucose intolerance, osteoporosis, and increased risk of infection, gastrointestinal symptom, and neuropsychiatric symptom. The next treatment, next steroid that we can use is dexamethasone, that is 20 to 40 mg orally for 4 days, every 2 to 4 weeks, maximum of 4 cycles. So side effects are same as that of the prednisolone. Then the next treatment line is can be used is immunoglobulin, that is 0.4 mg per kg of body weight intravenously for up to 5 days or 1 gram per kg for 1 to 2 days. Side effects are headache, aseptic meningitis, and renal failure. Then thrombopoietin receptor agonist is romiplostim, eltrombopag, and the avatrombopag. Romiplastin can be used in the dose of 1 to 10 microgram per kg subcutaneously once in a week. The side effects are headache, muscle ache, possible increased risk of thrombosis, and the myelofibrosis. Eltrombopag can be used in the dose of 25 to 75 mg orally daily. So the side effects are gastrointestinal symptom, transaminitis, cataract, possible increased risk of thrombosis, myelofibrosis, and should be taken 4 hours after and 2 hours before food containing catechins. Then avatrombopag, the dose is 5 to 40 mg orally daily. The side effect is headache, arthralgia, possible increased risk of thrombosis. Immunomodulator can be used is like rituximab, fostamatinib, azathioprine, mycophenolate mofetil, danazol, and dapsone. Rituximab can be used in the dose of 375 mg per square meter of body surface area intravenously weekly for 4 weeks or 1 gram administered twice with 2 weeks between symptoms. Lower doses, that is 100 to 200 mg weekly for 4 weeks, have also been shown to be effective. The side effects are insulin-like side effects like chills, upper respiratory discomfort, bronchospasm, neutropenia, hypogammaglobulinemia, serum sickness, increased risk of infection, progressive multifocal leukoencephalopathy, and should not be used in patients with evidence of active HBV infection. Fostamatinib is used in the dose of 50 to 150 mg twice daily. The side effects are hypertension, nausea, diarrhea, transaminitis. Then the next drug that we can use is azathioprine. The dose is 1 to 2 mg per kg orally. Maximum is 150 mg orally, 150 mg daily. And the side effects are weakness, sweating, neutropenia, transaminitis, increased risk of cancer. The next drug is mycophenolate mofetil. The dose is 500 mg orally twice daily for 2 weeks with gradual increase to 1 gram twice daily. Side effects are headache, gastrointestinal symptom, fungal skin infection, teratogenic in pregnancy, and increased risk of cancer. Then we can also use danazol in the dose of 400 to 800 mg orally daily. The side effects are hirsutism, acne, amenorrhea, transaminitis. This androgenic agent should not be used in patients with prostate cancer. Then we can also use dapsone in the dose of 75 to 100 mg daily. The side effects are gastrointestinal symptom with hemoglobinuria, rash, hemolytic anemia in patient with G6PD deficiency. So the key points are ITP is diagnosing patient with platelet count below 1 lakh per cubic millimeter in whom other causes of thrombocytopenia have been ruled. Patient with ITP who present with serious bleeding typically receive platelet transfusion, glucocorticoid, and intravenous immunoglobulin. In patients with no bleeding or non-serious bleeding, treatment decisions are guided by patient's platelet count, age, coexisting condition, and the preference. Glucocorticoids are used as first-line treatment, but prolonged use should be avoided owing to adverse effects. For patients in whom ITP do not remit or relapse soon after glucocorticoid treatment, other medication for which high-quality data include thrombopoietin receptor agonist and rituximab. Splenectomy is not recommended during first year after diagnosis of ITP unless medical treatment is not available. Otherwise, it is reverse for patient with ITP that is refractory to medical treatment. Thank you, guys.